So we'll start with our first resident, Dr. Thara El-Mugheri, diagnosis of new onset of pancreatic head adenocarcinoma in a patient with psoriasis treated with adalimumab. Welcome, Dr. Thara.
Good morning, everyone. I am Thara Al-Mughera, dermatology resident. I am from Prince Sultan Military Medical City in Riyadh. Today I will be presenting an interesting case that we have encountered in a clinic titled Diagnosis of New Onset of Pancreatic Head Adenocarcinoma in a Patient with Psoriasis Treated with Adalimumab. So, as we all know, adalimumab is a tumor necrosis factor alpha inhibitor that is widely used in dermatology for the treatment of moderate to severe plaque psoriasis. It was granted FDA approval in 2008 for the treatment of moderate to severe plaque psoriasis, and in 2017 for the treatment of fingernail psoriasis. So, the biologic agents can be used as a first-line treatment or in combination with other forms of therapy for the treatment of psoriasis. As we all know, these agents, they modulate and regulate the immune system. It is well known in the literature that these biologic agents are associated with the development of cutaneous lymphomas, as well cutaneous malignancies as well as lymphoma, but the incidence of solid organ tumors have been reported less frequently in the literature. So the objective of this study is to present a case of a new onset of diagnosis of pancreatic head adenocarcinoma in a patient with psoriasis treated with adalimumab. So we want to raise the awareness of possible association between the biologic agent and the incidence of solid organ tumor. So our case is a 51-year-old male patient known to have diabetes and heart failure with an ejection fraction of 45%. He is following up in our dermatology clinic for chronic plaque psoriasis. Patient was maintained on adalimumab 40 milligrams subcutaneously every 2 weeks with twice daily calcipotriene betamethasone topical treatment. Patient was followed up regularly every 3 months with no active new complaint. In June 2024, patient presented to our dermatology clinic complaining of abdominal pain and also jaundice, yellow discoloration of the skin as well as scleral icterus. So patient was referred to medicine for further investigation. So patient underwent abdominal ultrasound, and there was evidence of a dilated common bile duct with no obvious intraluminal obstructing stone. So patient was then further assessed with an MRCP and ERCP, and initial diagnosis of pancreatic head adenocarcinoma was established. So adalimumab was then discontinued, and patient was planned for surgery. So as you can see here, this is a multi-sequential MRI of the upper abdomen showing a hypo-enhancing mass. As you can see in the picture, there is a hypo-enhancing mass that suggests hypovascularity. So an initial impression of adenocarcinoma was made. So patient then underwent Whipple procedure, and the excised mass was then sent for histopathological examination, and the histopathological examination was consistent with invasive moderately differentiated ductal adenocarcinoma, tumor size of 1.9 centimeters with positive lymph node involvement. So, as we all know, psoriasis is a common chronic inflammatory condition, immune-mediated disease that carries approximately 2 to 3% prevalence of the world's population. So for our case, we revise the literature using the research engine, PubMed and Medline, and we found only a single case that was previously reported with a similar presentation of pancreatic head adenocarcinoma. However, unlike our patient who was a biologic naive patient, this patient was treated with 2 biologic therapies, infliximab and adalimumab, for a period of 2 months and 4 months respectively. Otherwise, our case is unique, and it was not previously reported before that monotherapy of adalimumab associated with solid organ tumor. So there is also one report stated a causal association where nucleolytic migratory erythema, which is a characteristic rash frequently associated with the glucogonoma syndrome, was observed after months of adalimumab exposure. So this patient is known to have ankylosing spondylitis. He was treated with adalimumab for a period of 6 months, and then he developed this nucleolytic migratory erythema-like rash, however, with a normal glucagon level and also normal zinc level. So the conclusion of our case is that whether or not there was a direct causation between the development of solid organ malignancy and adalimumab treatment, we would always encourage close, diligent follow-up of these patients. We have to always screen those patients, asking them about any active complaints, any P symptoms. We also have to follow their labs and frequently anticipate the possibility of solid organ malignancy or malignancy in general. Thank you so much.
Hello. Thank you, Dr. Tara. Well presented. Our next candidate is Dr. Jawahar Al-Shamsi. She will give a presentation titled Behind the Dark Mask.
Doctor, can I ask a question, please? Yes. One question.
Sure.
For how long he has been using the adalimumab before the diagnosis of adenocarcinoma? Very interesting case.
For 2 years.
2 years,
Yes.
okay.
He has been, after we discontinued adalimumab, patient was then shifted to Skyrizi because of the frequently reported incidents of malignancy and neoplasm in general associated with adalimumab. Skyrizi is a new emerging treatment that we thought it's much safer, so patient was shifted to Skyrizi. After the procedure, he's doing well, no relapse, and he is the patient is following up with us, and no active complaints. Okay.
Thank you.
Welcome, Dr. Jawahar, to the stage.
Good morning, doctors, colleagues. My name is Jawahar Shamsi. I'm a dermatology resident at Rashid Hospital. Today, I'll be presenting a case that was challenging and educational, entitled of Behind the Dark Mask. The skin spoke before the body failed. In this case, I'll be highlighting how a typical dermatological finding can unmask life-threatening severe systematic disease. So our patient is 60 years old, male, known to have type 2 diabetes, hypertension, prior diagnosed with interstitial pneumonitis. The patient was non-smoker. 3 months before the dermatological involvement, the patient presented with chronic cough, significant weight loss, and fatigue. Over the time, he wants to develop non-healing painful ulcer that on the hands and bony prominence, and that associated with the crustation and bleeding. At the time that patient presented to us, they refer him after he developing diffuse facial hyperpigmentation. So in general, the patient was ill-looking, bedridden, vitally or stable. In systematic examination, there is largely unremarkable finding, no lymphadenopathy, and there is no focal muscle weakness. He is complaining of generalized weakness. When we did the lifting arms over the head, were normal, and squat test was not done because of the patient's situation. Okay, in dermatological examination, patient presented with diffuse facial hyperpigmentation with mild scaling and dryness, notable that the sparing preorbital skin. On the hands, there were well-demarcated, sharply edged ulcers, and it's really painful. The floor of the ulcer shows depression, pale, avascular center, the base was soft, and the surrounding area, skin were edematous and pigmented. On the knee, as you can see, there's a lower leg shows diffuse pigmentation, scaling as well, and there's two well-demarcated ulcer on the right knee. It's bunched out, irregular margin, soft base, the floor were dry, and the necrotic tissue was seen. So our differential diagnosis, we had like a huge list of differential diagnoses, but we narrowed them. First, we are thinking about primary adrenal insufficiency, Addison disease, a suspicion because of diffuse hyperpigmentation, fatigue, weight loss. We ruled it out because patients were vitably stable, no hypotensive, electrolytes, sodium, potassium were normal, no salt, graving. Then we are thinking about drug-induced hyperpigmentation, but the history of a chronic or prior exposure to medication known to cause pigmentation is not fitting with the presentation that we are seeing, so we ruled it out. Then we thought about cutaneous T-cell lymphoma, Sézary syndrome. I know it's not typical, but we suspected because of the age, the weight loss, diffuse rash, and the status, we ruled it out after doing the blood film and skin biopsy. And we are thinking about dermatomyositis, which is a typical form. The patient having cutaneous ulceration, dysphagia, interstitial lung disease. So we did the investigation. We start with the chest imaging, chest X-ray, CT scan, both revealed that the patient have chronic interstitial changes. In the lab, interestedly, that the muscle enzymes were normal, and CBR was a bit high, ALT, liver enzyme was a bit high, and the cardiac was, troponin is really high, and the BNP is high. They did the ECG for him, echocardiogram were normal, so like, something wrong is here. Then we did the skin biopsy. The skin biopsy shows focal basal cell vascularization, capillary ectasia, superficial prevascular lymphatic infiltrate, the immunomarker were normal, and all these findings was suggestive more autoimmune connective tissue disease, and this is like it's supported with clinical finding as well. So we did more investigation. We ordered serology myositis-specific antibodies. And what we find that RO52 was positive, and SSA-RO strongly also positive, which is suggesting an autoimmune connective tissue disease. And what we found that the patient have MDA5 antibodies positive. So we reached to the final diagnosis, anti-MDA5 antibody-associated dermatomyositis, which is a typical form or one of the aggressive variant of dermatomyositis that when the patient have it will result in a poor outcome. So the discussion. So those are the subtypes of dermatomyositis. The classical type that we all know from the books, that the patient presented with proximal muscle weakness, the cutaneous feature, heliotrope rash, gut reflex, nail capillary changes, and there is a key associated with high creatinine enzymes and inflammatory myopathy. What we have in our patient, anti-MDA5 associated dermatomyositis, its muscle involvement is absent or minimum, and it is more vasculopathic process rather than inflammatory process. So patient presented with skin ulceration, necrosis, and rapidly progressive interstitial lung disease. So what's MDA5? Is melanoma associated, I forget it, melanoma something. Melanoma associating factor 5. It is acts as a cytoplasmic viral RNA sensor.
Dr. Jawahar, you have half a minute more.
Okay. So it acts as a cytoplasmic virus RNA sensor, detects double-stranded RNA, activates type 1 interferon. When there is antibodies, the interferon pathway will be overactivated, causing the endothelial damage that we saw that in the skin. We have deep bunched out necrotic ulcer and rapidly progressive interstitial lung disease and elevated cardiac enzyme. So connecting the dots, the patient has severe cutaneous ulcer, interstitial lung disease, heart disease, and systematic symptoms. The their management is require multidisciplinary approach, and the main primary treatment is the infection control, aggressive wound care for a chronic pressure ulcer, and skin barrier, reestablishing the skin barrier. So the course of the patient was declined because of the unhealed ulcers. This patient passed away because of the septic shock and declining of the cardiac function. So key lessons from this case: a typical presentation, dermatomyositis may present late with a hyperpigmentation rather than erythema. MDA5 prognosis is a bad or poor prognosis if it's present, and absent of muscle involvement is a typical finding in anti-MDA5 dermatomyositis. Cardiac involvement also can be considered severe in this type, and infection as the drive of mortality in most of these patients.
Thank you. Thank you very much. Thank you. Thank you. Our next speaker is Dr. Fida Anjoum. It's difficult to read this. Hyalohyphomycosis cyst on the hand caused by... I'll let you finish the...
Assalamu alaikum. Good morning. I'm Dr. Fida Anjoum from Yanapoya Medical College, Mangalore, India. My topic is hyalohyphomycotic cyst on the hand caused by Sarocladium keeliense, a case report. Introduction. Subcutaneous fungal infections are rare in the immunocompetent. Sarocladium keeliense is an ubiquitous fungus. It has rare etiology for disease. The mycotic cysts are almost never the first diagnosis. The diagnosis require clinical suspicion and specific investigations. History. A 60-year-old diabetic farmer was admitted for fractured shaft of the left femur with external fixator. There was a painless cystic swelling on the dorsum of the right hand since 10 years. There was no history of preceding trauma or systemic symptoms. Multiple attempts were done at drainage and antibiotics were given. On clinical examination, there was non-tender lobulated cystic swelling, extension onto the middle finger dorsum, and the overlying scale was seen proximally. The differential diagnosis considered were atypical mycobacterial abscess, tubercular abscess, pheohyphomycotic cyst, and mycetoma. The microbiology, cystic fluid, gram stain, and bacterial culture were negative. FNAC and microscopy of cystic fluid showed non-pigmented hyphae. On fungal culture, macroscopic growth, the whitish colony and yellow on reverse were seen. The slide culture and lactophenol cotton blue mount showed hyaline septate and branching hyphae giving rise to long conidiophores ending with phyalates. These are the fungal culture plates. The first one is KOH and the second one are the fungal culture plates. Histopathology. The central cavity with foamy histiocytes, inflammatory debris were seen. It was surrounded by dense chronic inflammatory infiltrate with foreign body giant cells. Few giant cells showed past staining and fungal hyphae-like structures. GMS and ZN stains were negative. There was no casseting granuloma. These are the histopathological pictures. The diagnosis was hyalohyphomycotic cyst. Surgical excision was done. The patient was initiated on 6 months of itraconazole therapy. Clinical resolution was achieved. The first photograph was taken when the patient presented, and the second one was sent by the patient 6 months after the itraconazole therapy. We can see complete resolution of the lesion. Discussion. Hyalohyphomycosis refers to infections caused by non-pigmented septate molds. examples such as fusarium, telleromyces, acrimonium, or serocladium. It is mostly seen in immunocompromised, but also seen in healthy individuals. There is no specific morphology. It can present as abscess, cyst, or cellulitis. The diagnosis requires fungal culture. Histology may be non-specific. The atypical features in our case was the patient did not recall any trauma, but he was farmer by occupation, which predisposes the patient to trauma. The histology was suggestive but not definitive. PAS was positive, whereas GMS was negative. Few hypomycotic cysts are more commonly reported than hylohypomycotic cyst. The hylohypomycosis are rarer and more it has heterogeneous presentation. Relevance and significance is it is caused by an ubiquitous pathogen, it has rare disease manifestation, and it is potential for fatal dissemination. The complete cure is achievable with timely treatment and diagnosis. These are my references. Thank you.
Any questions from the judge? We still have 1 minute. Okay, thank you.
Hello. Thank you, Dr. Fida Anjum. Next, I invite Dr. Rana Ganawi to present the presentation titled The Silent Nodules, Unmasking Knuckle Pads in a 40-year-old woman.
In the name of Allah, the Beneficent, the Merciful, this is Dr. Rana Ganawi from Sudan, dermatology resident. I will present a simple case, and I want to highlight a very simple information, okay? Okay, this is 40-year-old woman who presented with asymptomatic, slowly progressive firm nodule over the dorsal aspect of the proximal interphalangeal joints of both hands and metacarbophalangeal joints of the right index. The condition has been present for several months with no associated pain, pruritus, trauma, or preceding inflammatory dermatosis. Let us see the picture, okay? There is hyperpigmented dark nodules over the proximal interphalangeal joints, okay? And it's slightly hyperkeratotic. This one. So the diagnosis is knuckle pads. And how to manage it? It's just reassurance. You have to reassure your patients that it's a simple condition. There is no risk of malignancy. It's a benign. And we prescribe for her a topical salicylic acid cream just as keratolytic. So information about knuckle pads. Knuckle pads, also known as garrot pad, heloderma, or holoderma. Definition, knuckle pads are benign fibrous thickening over the extensor surface of the interphalangeal joints, classified as a form of superficial fibromatosis. The etiology, it's occur in children, adolescent, and young adults. Maybe it's sporadic familial and may be associated with repetitive mechanical trauma, like in bulimia nervosa. Some patients, they do like this, which is called Russell sign, okay? The exact pathogenesis is unclear, but there is predisposing factor like friction, pressure, genetic predisposition, or it may be associated with disorders like Dupuytren contractures, Lederhaus, or Peyronie's disease. What is the clinical picture? It is asymptomatic, well-defined hyperkeratotic nodules or plaques located over the extensor aspects, mainly the knuckles, and is usually asymptomatic. It's bilateral and symmetrical in many cases. So what are the differential diagnoses? The differential diagnosis, it could be rheumatoid nodules, gouty tophi, callosities, granuloma annulari, xanthoma, or ganglion cyst. So the diagnosis is mainly clinical. when you found a dark or hyperpigmented papules or plaques, nodules or plaques over the extensor aspects. And if we did a biopsy, we will find dermal fibrosis, thickened collagen bundles, and fibroblast proliferation. So what is the management? Management is reassurance mainly as the condition is benign, and avoid repetitive trauma in case of trauma or psychiatric patient. Limited benefit from topical keratolytics. We can do topical or intralesional corticosteroid, but from surgery there is the risk of recurrence. So I want to highlight there is many syndromes that is associated with knuckle pads, like Part-Penfrey syndrome, which is autosomal dominant disorder characterized by knuckle pads, sensorineural deafness, and leukonychia, in addition to the thickening of the skin of the palm and sole, which is palmoplantar keratoderma. This is the picture, like palmoplantar keratoderma. And in addition to the acrokeratoelastoidosis of costa, which is a condition where is a familiar small firm papules or marginal keratoderma, develops on the hand and feet along with the knuckle pads. This one. And epidermolytic palmoplantar keratoderma, it is specifically associated with mutation in keratin 9 and keratin 1 gene, which can cause both thickened palm and knuckle pads. So, Part-Penfrey, acrokeratoelastoidosis of costa, and in addition to the epidermolytic palmoplantar keratoderma. This one. So, my home messages is knuckle pads are benign and non-inflammatory. The diagnosis is mainly clinical, and the treatment is usually unnecessary. Correct cognition prevent misdiagnosis and overtreatment. I want to end with the famous quote by the Benjamin Franklin: "If you fail to plan, you are planning to fail." And thank you.
Thank you. Just one question. How would you differentiate that from the Gottron's papules in dermatomyositis?
Okay. There is the reddish papule, mainly in the Gottron papule over the extensor side, but in the knuckle pads, it's well-defined in addition to the darkly pigmented border.
The location is the same?
Yes, maybe it's the same here, but mainly it's proximal and bilateral, and there is well-defined hyperkeratosis. The hyperkeratosis is the key differentiator.
To go with the knuckle pads?
Knuckle pads.
Okay, thank you very
Yes.
much. Any other questions from the judges? Okay, thank you. Thank you. Our next speaker is Dr. Hamd Al-Falasi, 3-year recurrent cheilitis revealing hidden disease.
Hi, good morning, everyone. I'm Hamd Al-Falasi, dermatology resident at American Hospital, and today I'll be presenting a case of 3-year recurrent cheilitis revealing hidden disease. So disclaimer, no conflict of interest, and the patient consent was obtained. So our patient presented to the clinic with 3-year history of recurrent lip rash that was episodic and not responsive to typical treatment. He's a 20-year-old male that has no past medical history and has family history of atopy. His brother has some of the milder symptoms, but nothing else. So it occurred over the 3 years. He had associated symptoms of dryness, burning, scaling, discomfort. He did not associate it with any clear triggers. He's a non-smoker, follows a regular diet, and was previously labeled as contact dermatitis, where patch testing was done, came back as negative. And he has tried topical steroids and topical tacrolimus with some relief, but then it relapses. So this is the patient. He had erythematous background, silvery scales, as you can see, involving the upper lip and the lip commissures. There is also some fissuring, and as you can see, some of honey crusting on the lip commissures. So we did a full skin exam, and it revealed a axillary rash that the patient was not complaining of. It did not have any associated symptoms. As you can see, it's erythematous, well demarcated, and that raised suspicion to do a biopsy. Now, systematically, the patient did not have any other skin findings, no nail findings, and no joint pain. So far, we're thinking about contact dermatitis, erythema dermatitis, inverse psoriasis for this patient. Investigations were done. He had vitamin D deficiency, was being supplemented. Everything else came back as non-significant. So the biopsy came, and I think it can be appreciated from here that the patient did have some hyperkeratosis, parakeratosis can be seen, lymphocytic infiltrate, and significant subpapillary thinning. And kind of like we see here. So we came with a final diagnosis of lip psoriasis presenting with an axillary rash. Now, with regards to this patient, since he did experience trial of topical therapies with partial or temporary improvement, the next logical step to be systemic treatment, which is biologics. So, brief discussion about what the literature says. Since the 2000s, only 15 cases have been reported with lip psoriasis. Some proposed triggers were there, such as mild trauma, lip licking, protruding teeth, Kubner phenomena-like presentation, and genetic susceptibility. All patients did have common clinical picture, which is the fissuring, scaling, dryness, and often misdiagnosed for months to years. So this is a case that I would like to compare to our patient. She's a 45-year-old female that had 6-month history of severe scaling and fissuring on both lips. Upon taking history, she said that she did have a scalp lesion that presented 2 months prior to the lip rash. And so they used a dermatoscope where it showed the regular dotted pattern on the lip, and then they diagnosed with lip psoriasis. So she was treated with topical steroid for the lip and the scalp, and that resolved. In comparison to our patient, they both did have persistent lip involvement. Both we did have to look at the other side of the skin, which showed axillary in our patient and scalp in this patient. So it is very important to do a full skin exam whenever you have a patient that is. So the second patient that I would like to discuss is a 14-year-old male, and he presented with yellowish scaling of the lips. It's been persistent for 2 years, and it's very easily detachable. The scales, upon descaling it, there would be a positive auspicious sign. So they tried some topical steroids, did not work with this patient, so they ended up doing incisional biopsy, which came back as psoriasis. It was a solitary lesion, so he did not have any other rashes on the body, and so they did do UVB, did not improve, so eventually they started him on adalimumab, which he had complete remission in 6 months. So in comparison to our case, both are young females, they both failed topical treatment, so the next logical step would be systemic treatment, and that would be it. So just treatment landscape of what has been provided in the literature. So topical steroids, you have tacrolimus, and biologics. Just a summary of all of the cases that I was able to find in the literature. So the final takeaway, when we have chronic colitis, I think it would be a thought to have maybe this patient do have psoriatic colitis, and we should do a full skin examination when it comes to these patients. So maybe they do have another lesion in the body. If not, to consider biopsy to help orient the diagnosis. This is my references, and I'd like to share acknowledgements. Thank you so much.
Thank you, Hamda. This is an excellent case. I've never seen psoriasis on the lip.
Yeah, sorry.
Yes, very, very rare case. Any questions from the judges?
Yes.
May I have a question? Did you consider the differential of exfoliative cheilitis, which can present really similar? And where was the site of the biopsy that you took?
So the site of the biopsy was on the axilla. We did not opt for the lip since it's a cosmesis and a functional area. We did not, since he did not have any other symptoms of leading to colitis, and he was refractory to medication, we did not consider exfoliative colitis for this patient.
Thank you so much.
Chris, any questions? Thank you.
Thank you. Thank you, Dr. Hamda, for the informative talk. Next, I invite upon Dr. Khalif Al-Maheri for his talk titled Early Onset Poikiloderma in a Pediatric Patient, a Diagnostic Challenge.
Assalamu alaikum. So my name is Khalif Al-Maheri. I'm a dermatology resident from Dubai. The title of my presentation today is Early Onset Poikiloderma in a Pediatric Patient. So let's call our patient Rashid. Rashid is a 13-year-old Emirati male who had main concern of poikiloderma on face, extremities, and buttocks as well. So it started as erythematous vesicular eruption just 5 months after birth, and it was worsening with sun exposure, and it was gradually evolving to the limbs, mainly the extensors and the buttocks as well. So the main things in history is that his parents are first-degree cousins, and he was atopic as well. He had eczema and asthma. To make it more easy, we will speak about the timeline of the clinical feature. So as soon as he was born as a preterm via C-section with a low birth weight, and by 5 months, he had this erythematous vesicular eruption on the cheeks. His hair was thin as well, and he had some eczema. By 1 year, dysmorphic features were more evident, so he had saddle nose, low set ears, as well as microcephaly. By 2 years, the sun was affecting his skin, so there was a shift toward poikilodermatous changes on the same areas we mentioned, and it was also increasing. By 4 years, he had recurrent vomiting and diarrhea, and by 5 years, he had a huge problem, which is recurrent fracture from minimal trauma requiring frequent admission to hospital, and it was bothering the parents a lot. As well, he had failure to thrive, short stature, and bilateral clinodactyly. By 5 years, the quality of teeth was bad. By 6 years, he had asthma and recurrent otitis media, and by 8 years, he had recurrent palmoplantar hyperkeratotic lesion on weight-bearing area, as well as nail dystrophy. So via examination, the patient is vitally stable, alert, but as mentioned before, he had dysmorphic features on his face. Dermatologically speaking, in the skin, as you can see, mottled hyper and hypopigmentation, mainly on cheeks and extensors as well. As you can see, the hair is very thin, and also it was affecting the eyebrows and the eyelashes. He had also the hyperkeratotic lesion on the plantar surface, as you can see, mainly on the weight-bearing area, as mentioned before. So we did some investigation. His labs were normal, and the skin biopsy from the poikilodermata area, it agreed with poikiloderma, with poikilodermatous pattern, like lymphohistiocytic infiltrate, pigmentary incontinence, and telangiectasia as well. We did also a bone scan because we want to have explanation of the recurrent fracture, and it showed very bad quality of the bone, osteopenia. So our top of the differentials are Bloom syndrome, Kindler, Werner syndrome, Rothman-Thompson syndrome, dyskeratosis congenita, and the other differentials in the list. So we conducted an MDTT, multidisciplinary team. We highlighted the main things: poikiloderma, hair abnormality, and the bone complications. So we sent blood for genetic test, which came homozygous mutation with RIC-QL4 mutation, and confirmed the diagnosis of Rothman-Thompson syndrome, which is an extremely rare entity, only 500 cases in the literature. It has autosomal recessive pattern, and the main star of that disease is poikiloderma, or early onset poikiloderma. The problem or the challenge is that disease is high risk for malignancies, and it has two main types. So in type 2, there is the RIC-QL4 mutation. The skeletal abnormalities, growth retardation, genomic instability is more with type 2. As I mentioned before, osteosarcoma as well as other skin cancer is more probable with type 2, where in type 1 there is the AA and APC1 mutation, as well as juvenile cataract is more common with type 1. So pathogenesis of the type 2 is, as mentioned, the mutation in RIC-QL4. There will be defective DNA helicase function, impairing DNA replication and repair, and affecting the rapidly dividing cell. For example, in skin will cause poikiloderma, in hair follicle will cause thin hair, and in bone will lead to osteopenia and recurrent fracture. As it will also increase the risk of osteosarcoma and other skin cancer, classically squamous cell carcinoma. The clinical feature of that disease that it will appear early, 4 or 5 months only. Cutaneous findings are erythematous vesicular eruption that will shift to poikiloderma with photosensitivity, as well as sparse hair, nail dystrophy, and the hyperkeratotic lesion. Speaking about the bone, short stature, osteopenia, and recurrent bone fracture. By growth also, it will affect the growth, it will lead to failure to thrive, as well as chronic vomiting and diarrhea. So the main things is in the management, we need to counsel the parents, tell them the likelihood of the future offsprings to get affected. Photoprotection is very important, especially to decrease the risk of cutaneous cancer, such as SCC. Malignancy surveillance is crucial as it is linked with prognosis of the disease. Mentioning osteosarcoma is directly linked with prognosis of that disease. Co-managing as MDT, we need to get the other teams on board and monitor the growth of the patient. Also topicals like keratolytics for the hyperkeratotic lesion. So this brings me to the last slide, which is a genodermatosis may shape Rashid's skin, but it will never define his ambitions. These are my references. Thank you so much.
Thank you, Dr. Khalifa. Any questions for Dr. Khalifa? I have a question.
Sure.
Will bisphosphonates help a patient like this one
I
for
didn't hear you,
strengthening the bone? Alendronate or any bisphosphonates?
Yes, so they started him on such medication and to just support the bone. They also were thinking of giving him growth hormone, but it can increase the risk of osteosarcoma and other malignancies, so they didn't give him.
Thank you so much, Doctor.
Thank you so much. Bye-bye.
Thank you, Khalid. Okay. Our next speaker is Dr. Noor Yahya, chronic struggle with a refractory rash, a diagnostic dilemma, and a therapeutic challenge.
Good morning, everyone. My name is Noor Yahya. I'm a family medicine resident, and today I shall be presenting my case. Now, imagine seeing many specialists in search of answer to your concern, only to be left with uncertainty. Not every story has an answer. So I present my case of a 68-year-old retired male, multiple comorbidities and a history of atopy, presenting with an itchy rash affecting his whole body. So basically, it started 5 years ago during COVID, and he describes it as intermittent in nature, distributed over his lungs and extremities. It happens in flares, and he presented to the clinic because he had the flare just a week ago. According to him, it's exacerbated by heat, certain foods, fresh vegetables, and relieved by hot shower and steroids. So basically, his known case of diabetes, multiple comorbidities, atopy, and basically, as per his medication history, he's taking medications to manage his diabetes and dyslipidemia. He has history of taking Xolair because he was diagnosed at some point of having urticaria for 10 months and it didn't work. And he also has history of taking Dupixent for 9 months because he was diagnosed by a different dermatologist as having eczema, and again, it didn't work. He also has history of doing phototherapy sessions because in a previous biopsy, he was diagnosed as mycosis fungoides, and it didn't work as well. So the only thing that worked for him were the over-the-counter steroids during flares. His family history is unremarkable. He doesn't smoke, drink, and he used to work as an electrical engineer, and he has a history of sun exposure. So basically, the review of system, he also has bilateral knee and shoulder pain when he's exposed to cold, bloating, and occasional diarrhea. He denied constitutional symptoms, shortness of breath, angioedema, photosensitivity, anaphylaxis, purpur, or anything in that sense. So on physical examination, he has a well-demarcated erythematous, plaques, patches, and nodules distributed over his trunk and extremities, and the wheals used to last more than 24 hours, according to him. And so basically, later on in the dermatology clinic, another biopsy was taken, and it has diagnosed him as urticarial vasculitis. And later, he was referred to the rheumatology clinic. So his initial labs showed eosinophilia and IgE levels of 5,000. His immune workup was unremarkable. So no input from the rheumatology side, since all his labs were negative. And his biopsy that was done in the derma clinic showed hyperkeratosis, perivascular infiltrate, and composed of lymphocytes and eosinophils, restricted to only the blood vessels, and that was supportive of urticarial vasculitis. So the course of this patient, basically, he has disengaged from the healthcare system ever since because he just thought that there isn't a good treatment for his case. And he kept going to so many dermatologists, and all of them having different opinions and different lines of treatment. So this case not only highlights the diagnostic challenges of urticarial vasculitis, but also how delayed diagnosis and the absence of standardized guidelines can impact patient trust and the long-term engagement with care. So it's a normocomplementic urticarial vasculitis, given his complement levels are normal. So just few pearls about urticarial vasculitis. It's leucoclastic vasculitis characterized by inflammatory insult to the small blood vessels involving the capillaries, the arterioles, and the venules. And usually it's unknown, but it has been linked to many causes or triggers like drugs, infections, autoimmune connective tissue disease, myelodysplastic disorders, or malignancy. And actually, it's very complicated disease and persisting for weeks, years, and it can reoccur immediately or it can abort on its own. And treatment typically involves addressing underlying autoimmune conditions and managing symptoms with medications like antihistamine, corticosteroids, or other immunosuppressive drugs. Thank you. These are my references.
Thank you, Dr. Noor. Any questions for Dr. Noor? Okay, thanks. Next, I would invite Dr. Maha Al-Husni to present Koebner phenomenon and cutaneous leprosy, a case report.
Assalamu alaikum. So this is Dr. Maha from Oman Medical Specialty Board. I'm dermatology resident. So my case today is about pseudokoebner phenomena in leprosy when trauma unmasks leprosy. So I wanted to start with leprosy cases in worldwide. Worldwide, we are still getting 200,000 cases per year, but in Oman and Gulf area, it's very rare disease with elimination achieved. In Oman, the statistics say that we get less than 1 case per 10,000 population per year, but we still getting occasional sporadic cases due to migration. So to start with my patient, she is a 64 years old female with hypertension, diabetes, and dyslipidemia and G6PD deficiency. So the story started in 2024, where she got asymptomatic, slowly progressive facial nodules, and with no fever, no sensory or motor deficits, no joint pain, no travel or sick contact history. And she was seen by a dermatologist where she was given topical steroids with no improvement. Then in 2025, the disease progressed. She got increase in number of facial nodules, spread to forearms, lower lip swelling, and unintentional weight loss, which unfortunately it was not documented. Then in June 2025, when she was presented to us, she had linear raised lesions over the back following the lines of the trauma where she got cupping therapy at that time. So these are the clinical pictures of the patient. As we see, the secret multiple erythematous nodules over the cheeks and lower lip swelling. Also, she got in the distal forearm similar lesions, and the interesting part is that she had raised linear lesions along the trauma caused by the cupping therapy she did over the back. So we took biopsy from the back and the forearms, and we came to see that there is dense lymphocyte infiltrate along the small nerve bundles in the deep dermis, and multiple granulomas surrounded by lymphocytes. So we came to know that this is granulomatous disease. So we sent for Wade-Fight stain. In Wade-Fight stain, we saw numerous acid-fast bacilli in the dermis. So we came to the diagnosis of leprosy. So pseudokoebner phenomena in leprosy led us to this diagnosis. We know the difference between pseudokoebner and Koebner phenomena. Koebner phenomena when there is appearance of dermatosis like vitiligo along the lines of trauma. But pseudokoebner phenomena, it's like auto-inoculation or spread of infection along the sites of trauma. So the pathogenesis behind this is that there were pre-existing Mycobacterium leprae in the dermis. After the cupping therapy, there were microbreaks in the dermis, allowing these acid-fast bacilli to move to the adjacent traumatized areas and proliferate there, cause inflammation and new leprosy lesions along the sites of trauma. So we referred the patient to medicine. They started her on 1-year regimen of rifampicin and clofazimine with family screening and prophylaxis. We Followed here after 6 months of treatment, significant improvement with residual post-inflammatory hyperpigmentations as we see in the pictures. This is the back lesions and this is the face lesions. We see the improvement in the lower lip lesions. So pseudocobner phenomena in leprosy, it was described in the literature first after vaccination and after tattooing, and we got few cases only after tattooing, post-inoculation leprosy after tattooing worldwide. So the take-home message of this case is that pseudocobner phenomena can occur atypically in leprosy, and recognition of this case or this pattern is crucial, particularly in our area, which is low endemic area, to avoid the delay in diagnosis, treatment, and to avoid complications. Thank you.
Thank you so much, Dr. Maha. Any questions for her?